Hello, my colleagues. Welcome again in a new session. Today, our session about pediatric cases, mainly pediatric neurology. Welcome, concentrate. We hope best wishes for our colleagues who have tomorrow or after tomorrow Viva exam. This is a 7-year-old female patient presented with childhood gelotic seizures and developmental delay.
Okay. I've been provided with sagittal cuts for MRI for a child brain. This is T1. Just I will have a look. Okay. I will start from. Okay. This 7 years old child coming with seizures and developmental delay.
Yes.
I'm just looking for the abnormality. I can see that there is abnormal mass lesion hypointense signal noted related to the pituitary fossa, but I am okay, and it's enlarged in size. It's extending upward to the optic chiasm and extending downward, compressing the medulla oblongata and bones.
Where is the exact location? Are you sure this is the pituitary?
No, I'm not sure that it's exactly in the pituitary. It's maybe a supracellular region.
Yes. So this is supracell.
Okay.
Mm-hmm.
It's a hypointense in signal in T1. I wanted to look for the other signals in this. Just I want in this sagittal view to be sure that there is no evidence of. Okay, I can see the fourth ventricle. I want to look for the other no any brain herniation, so there is no any crowding in the foramen magnum. So I can exclude this. Just I want to look for this in other sequences.
Take what you want.
I want to look for it in the post contrast.
I
And
think,
also,
okay, there are no post contrast here.
no
You
post
can,
contrast.
this
Okay, so
is,
in T2 and the flare?
is this flare?
No, this is just 1 second. No, this is diffusion.
Okay.
Okay. In the diffusion, it appears no restricted diffusion. No restricted diffusion noted within the lesion. Okay. So as there is no more no if no T, is there is any T2 for this lesion? Okay. In the T2, it appear also hypointense in signal. So it's now this lesion is hypointense in T1, hypointense in T2, and does not show any restricted diffusion. I can, in the sagittal view, separated it from the midbrain. I'm thinking about craniopharyngioma as it's a supracellular region coming with this age, and also there is in the T2 there is evidence of marked hypointense signal noted within, which could be calcification.
Use the mouse.
Or
Leave
okay.
the mouse 1 second. Look here. This is perfusion. What happened here?
This is what? Sorry.
Perfusion.
No.
MRI
Yeah.
perfusion.
Yes. I don't know. I really don't know about this.
See. The red color is the highest perfusion. The yellow is the least. This yellow, this is the lesion. This is the blue, sorry, not yellow. The blue
Yeah.
is similar to, what is this? What
Brain
is it?
parenchyma.
Okay,
This is
excellent.
okay. So this
Okay,
could be something like hamartoma or gray matter
yes,
abnormality
yes,
in abnormal location.
yes,
Uh,
yes. So the most probable diagnosis here, tell me,
hmm. Could be
tell me.
heterotopia.
No, no,
Even is
no. See, heterotopia, something inside the brain itself.
okay. So it would be a hypothalamic hamartoma
Excellent. Why? Because
because it does
see,
not.
yes, yes, tell
I
me.
was going to say it's a hypointense signal in T1 and hypointense signal in T2 with
No,
no
see, see, it is iso-intense. Look here, it is
okay,
iso-intense to the brain overall, especially to the
okay,
cortex. And
okay.
here, it is iso-intense to the gray matter. I informed, I think yesterday or day before, when you are confusing, tell the examiner it is compare with something, at least here with the gyri. Doctor, it is
Yeah.
iso-intense to the gyri. Okay, if you compare with the white matter, something else. But it is very similar in signal in gyri, in T2 and in T1. So it is
Oh,
an ectopic tissue, hematoma. Otherwise, you can tell this is a supracellular mass for differential diagnosis. Like you told me craniopharyngioma. Okay, despite it must be in the bottom of your list, but no problem. Then what else? Tell me two or three glioma, for example. For example,
hmm.
but doctor, this is looks like hypovascular or isovascular
Yes.
to the white matter, like this.
Okay.
Last, doctor, this is according to the age and the complaint. It may be hypothalamic hamartoma. Okay.
Oh, okay.
Okay.
Yeah.
Thank you, doctor,
Thank you.
so much. My colleague, this is a hypothalamic hamartoma. The most tricky here, the size. Size is too large. Really, frankly, when I saw it, I was thinking about glioma. It was my first differential diagnosis. Okay, and I have a doubt it could be hamartoma, but I told myself it is very huge or very large. But this case gave us a lesson to enumerate the possible related diagnosis to the case, especially to the location. Number two, it is impossible to be craniopharyngioma because it is young. It is, it is 7 year old. Okay, and the craniopharyngioma in this age must be cystic, must be high or almost high signal motor oil signal in T1 plus calcification. Really, doctor, I think there are no calcification here. I think it may be something else. This is one. See here, no calcification. Thank you, doctor, so much. The case was tricky. Don't worry. Next candidate.
Assalamu alaikum.
Salam. Quest control, please.
Requested.
Okay, 5 year old female patient presented with headache for 1 year. Go on.
So it's working now. Okay.
Go on.
I am provided with the T1 sagittal weighted images of a child which present with headache.
Yes.
So there is marked hydrocephalus, dilatation of lateral third and fourth ventricle,
Okay.
foramen of Magendie is also dilated. There is no
Mm.
evidence of aqueductal stenosis.
Okay. What else?
Marked compression over cerebellar hemisphere, which is causing marked compression over cerebellar hemispheres, which is causing its thinning and displacement.
Yes.
Pituitary gland is normally visualized. Corpus callosum, there is thinning of corpus callosum due to marked hydrocephalus.
Okay.
I want to see the rest of images like post-contrast T1 weighted images to comment
Okay.
on any obstructing mass lesion.
This is the post contrast. Go on.
On post-contrast images, foramen of Luschka and laterally are also dilated.
Mm-hmm.
I am going upward. No enhancing mass lesion is appreciated throughout the ventricles. Only enhancing choroid plex is seen. There is periventricular hypointensities suggest transependymal seepage of the CSF, but I would like to confirm it on the FLAIR images if available.
Mm-hmm. So what's your diagnosis,
So
doctor?
in conclusion, it's a communicating gross hydrocephalus,
Yes.
which is causing marked thinning of the corpus callosum with transependymal seepage of the CSF without any obstructing lesion. I would urgently refer this patient to the neuro surgeon for the uh, to pass the BP shunt to relieve this obstruction.
In your opinion, could you tell me the cause here, the possible cause?
So it's a communicating hydrocephalus, but no definite obstructing lesion is appreciated.
Okay. Okay, but what is the expected cause here?
Yes, sir.
What is the cause of this obstruction? We didn't find the mass, we didn't find any obvious till now pathology. Give me a possible cause.
So maybe a web at the level of below the level of foramen of Magendie in the spinal canal. Because
Web
there is no
machine.
evidence of aqueductal
Yes,
stenosis,
excellent.
fourth ventricle is also dilated.
Excellent. Okay. What is the next investigation do you want to do for this patient to detect the exact cause?
CSF flow studies.
Excellent. Look here. What's your opinion? Yeah, go on. Scroll.
Okay. Will I request again?
No. Scroll.
Okay. Hyperintensity is appreciated in the region of the fourth ventricle
Okay.
with the prominent plovites and visualized sinuses are normally opacified with contrast without any evidence of thrombosis. So I think the pathology is below or at the level of foramen magnum, beyond which it is causing retrograde dilatation of all the ventricular chain.
Excellent, doctor. Excellent. This is communicating obstructive hydrocephalus, and we didn't detect any pause here. So the obstruction is below or at the outlet of the fourth ventricle. Okay. Look here, doctor.
Okay,
What
sir.
is this? What is this? What happened here? What is the procedure done
It's a,
here?
sir, I don't know, sir.
Okay, see, this is the lateral ventricle. This is the third
Yes.
ventricle. Okay. When you
Okay.
open the third ventricle with the suprasellar or the infundibular cistern. What is the name of this one? When you make an opening in a ventricle, what is the name?
Ventriculostomy.
Yes, this is the ventriculostomy. Okay, see,
Okay.
no any separation between the third ventricle and the supracisternal or the infundibular cistern here. Okay, thank you,
Okay.
doctor, so much.
Thank you, sir. Thank you.
Next candidate. Next
Hello,
candidate.
doctor.
Hello, welcome. Post control, please.
Yes, hello, doctor.
Yes, welcome.
Okay, so I've requested the control. Okay.
Yes. 12-year-old
Okay.
male patient presented with swelling of the left knee.
Okay. So this is a frontal X-ray of the knee. I can see that there is soft tissue edema overlying the medial aspect of the knee joint, and checking the bones, I can't see any fracture line. The epiphyseal the epiphyses are normal, normal bone density. So I would like to check other orthogonal views.
Okay, excellent.
Lateral view. Yeah.
Okay.
Okay, this is the lateral view. So there is joint diffusion uh, seen as a soft tissue density in the suprapatellar region. There is a loose body within the infrapatellar fat pad. I think three loose bodies,
Excellent.
small bone fragments, and I'm checking the patellar tendon. It looks thickened, but I can't separate the tendon from the soft tissue edema below or the effusion below the in the infrapatellar region. Checking the tibial tuberosity appears purposes appears normal. I can't
Okay.
see any bone
What
lesion.
is your next step?
I just suspected there is some cortical thickening in the distal femur, but I'm not sure if it's significant.
Okay.
In the posterior aspect.
Okay, what is your next step?
So I request an MRI because to rule out any ligamentous injury because there was soft tissue
And
edema
what
in the
about this
medial
one?
aspect.
No history. See, you forget the
Okay.
history. No history of trauma. You find the
No history of
swelling
trauma.
here.
Sorry. Okay.
Yeah.
Okay.
So, your
Okay.
MRI will not be for
MRI.
ligaments. Okay, this is
Okay.
MRI.
Okay.
Go on. Scroll, please.
Okay. So this is I think proton density but suppressed sagittal image. I can see that there is lobulated lesion seen in the suprapatellar and prepatellar regions, extending to the infrapatellar region, with cetaceans, internal cetaceans.
Okay, I'm going through this is the medial meniscus appear normal. There's some subchondral hypertensity here, but
What, give me any clue about this mass.
okay. I'm just trying to rule out any other lesions. I don't. Okay, anterior and posterior cruciates are normal. Okay. So this there is some hypo-intense foci within these
Okay. What does it
lobulated
mean?
lesions.
What does it mean?
Might be um, synovial hypertrophy
Okay.
or synovial osteochondromatosis,
Okay,
but
what
I can't
else?
see. Mm,
Look here. Leave the
okay.
mouse.
Okay.
Here we go.
Okay.
This is post contrast. What happened
Okay.
here?
So the lesion is enhancing.
Okay, and what is
So
this? What is this? What is this? What is this?
yeah, with hypointense foci.
This is the same foci that you see in X-ray.
Yeah. So they
So,
are calcific
okay, enhancing
lesions.
lesion, bright in T2 with calcification. What is the name of this pathology? Soft tissue mass. Like this, if we do MRI, we must do X-ray to see, especially for this. This is pathognomonic when seen inside this enhancing mass. Give me a description
synovial
at least.
chondromatosis or
No, it should be multiple.
PVMNS.
Okay,
Okay,
BVMN.
PVNS.
Okay, what else? But BVNS didn't show this is focal loose bodies.
Okay.
Okay. BVNS, this is a gradient, non gradient. What else? Enhancing soft tissue. Okay, this soft tissue is bright in T2 and multiple loose bodies. When you see enhance in the orbit,
if it's lipomatosis,
in the orbit, when you see enhancing mass and inside this mass there are philobuli or philobulus, what is your diagnosis? Anywhere.
Vein, like philobuli usually with venous malformation or venous.
Yes. So this is vascular tumor, hemangioma. Yeah. Okay. So it is hemangioma. Okay. Sorry. Hemangioma. Why hemangioma?
Hemangioma. Okay.
Yeah. Okay. So my colleague both, thank you, doctor, so much. My advice to you, see, no any problem if you didn't tell the exact diagnosis, but you see this lesion and then you shift to search for negatives, BCL, CL, despite the history with no trauma. No, in case of lesions like this, describe the lesion, describe everything, give differential, give management. See my colleagues to how many philippi. It was a high T2 like this, enhancing lesion, meningioma. Okay, okay, my colleague. This is not osteochondromatosis, because osteochondromatosis you should see many in the X-ray, many loose bodies, innumerable. This is mainly soft tissue mass lesion. if you told me, doctor, if you talk more about synovial pigmented villonodular synovitis, it will be acceptable. Why? A mass. But I think synovial pigmented villonodular synovitis will not enhance like this. This is avid enhancer. Thank you, doctor, so much.
Thank you,
Next
doctor.
candidate. Next candidate.
Yes, sir.
Welcome. Doctor, this is a 5-year-old, 5 months female patient with decreased visual acuity.
Okay, sir.
One second, leave the mouse.
Sure.
Leave.
Sir, I am
Go on.
provided with MRI post-contrast images. I am scrolling from top to bottom. I could appreciate. Sir, I'm unable to scroll properly.
No, scroll. Yeah.
Okay. Okay. So are you scrolling this?
I stop. Use the arrows.
Okay, sir. No, I think it's, I don't know, it's just jumping. Yeah, no, I think it's fine now. Okay, so I'm provided with MRI images T1 post-contrast in a patient who presented with strabismus, and I'm looking at the T1 images. On these images, I think I could appreciate that there is ventricles have a slightly abnormal configuration, and I'm unable to see the septum pellucidum.
Okay.
The patient presented with strabismus. I want to look at optic chaos. So can I have a look at some other sequence?
Yes, look at this one. Leave the mouse.
So I think the optic nerves are thickened and enhancing, but I would like to confirm. On the T2 sequence, no, it's working fine. Okay. I'm looking at the T2 sequences now. The maxillary sinuses are completely opacified.
Doctor,
Sorry.
the patient complained. Do you remember it?
Yes, sir. The patient presented with strabismus.
Patient has visual abnormality.
Yes, sir. Difficulty in the.
And
Sir, I'm looking at the globes.
Yes.
I
Stop
could
here.
appreciate
Stop
my.
here.
Okay,
Stop
sir.
here. Go up,
Okay, sir.
down, not up. Stop.
Sir, I could.
What happened? Tell me. You picked up
Sir,
something?
here, sir, just a mild perioptic nerve sheath fluid and something in the left ICA. No, this is cavernous ICA.
Doctor, look here, please. Look here. What happened?
Sir, I could appreciate mild atrophy of the left
Excellent.
temporal lobe. I could appreciate a prominent vessel over here. And
Don't worry about it. Look here, doctor. Compare optic nerves right with left.
yeah, sir, there is a atrophy of the left optic nerve, and the right optic nerve seems fine.
Okay. So, what's your differential diagnosis?
Sir, I'm thinking of septo-optodysplasia as there. I could appreciate septic
septum pellucidum atrophy and optic nerve dysplasia, I would like to see any possible association like schizencephaly that is highly associated with it, and other malformation as well.
Thank you, doctor, so much. See my colleague here. This is the right optic nerve. Leave the mouse, please. This is the left
Okay, sir.
one. Big difference. Follow both of them. You will confirm your doubt. See, doc.
Yes,
This
sir.
is the right optic nerve. This is the left.
Oh, yes. Yes.
Marked atrophy. Follow. Even the optic chiasm here is normal. At the right, here is markedly atrophic. Okay, my colleague. Plus this one. Absent septum pellucidum. When you see absent septum pellucidum, you should mention, you should talk about this. No, talk about septo-optic dysplasia, either to confirm or exclude. This is very important, my colleague. Okay, septo-optic dysplasia. What happened first? First, we see absent septum pellucidum. Then we confirm the atrophy of the left optic nerve. So a diagnosis of septo-optic dysplasia was made. This is related, the septo-optic dysplasia, this one, related to the holoprosencephaly, because this is a midline abnormality. Okay, my colleague? I mean related to the group of midline brain abnormality. Thank you, doctor. Next candidate.
Hello.
Hello, doctor. Doctor, this is 2-year-old, 2 days male patient presented with dyspnea.
2 days.
2 days.
Okay, this is of chest radiograph frontal projection of 2 days old neonate with history of dyspnea. I can appreciate that there are mottled lucencies involving whole of the left hemithorax. These appear as increased opacification with internal cystic areas. The right lung fields are clear. I can see the shadow of the thymus, sale sign of the normal thymus. The NG tube is seen well placed in the stomach. And both costophrenic angles are clear. So in summary, in this patient with respiratory distress, there is these mottled lucencies. These could be due to respiratory distress syndrome. Other differentials include
Doctor, where do you think
dyspnea.
the pathology, right or left?
Left side.
Okay. Which one? Upper, middle, lower zonal?
It is involving the whole of the left hemithorax.
No. This is the point. Request control, please. Request control.
Yeah, I have requested.
Show me where is the pathology in the left side.
So, a whole of the left hemithorax, there are
No. Not the left. Not the whole left hemisphere. Use the arrow and show me where is the pathology.
So this one, yeah, lower lobe, lower zone, left lower zone.
Why? Because here it almost looks like here, but here,
Okay.
what happened here? Describe. What happened?
Okay, there is increased opacification in the left lower zone, showing internal area, cystic areas. So I can put differential. I cannot see any clear boundary of the diaphragm, or this could be projectional. However, I could put differentials in this case. It could be due to intrapulmonary sequestration. Other differentials in this case would be diaphragmatic hernia, or other differentials include congenital neonatal pneumonia, perinatal pneumonia.
What is your next step?
I will inform the findings to the referring physician, and will suggest further imaging that would be in the form of ultrasound, first of all. And
what else?
Then CT with contrast to see the vascularity, anomalous vessels, anomalous blood supply of this.
Scroll, please.
Okay, these are axial section CT chest of the same patient. Further confirming increased density in the left lower zone with internal cystic areas. I need to look at the contrast enhanced imaging if available. Is there any?
No contrast. What happened here? Tell me.
Other differentials in this case would be congenital cystic adenomatide malformation, or CPAM, or known as CPAM, new name. So I will inform the findings to referring physician and will suggest referral to the pediatric pulmonologist for further management of this patient. Thank you.
Thank you, doctor, so much. My advice to all of you, my colleague, as I told you many times, when you see a film or an image, ask yourself in which pathway I'm running. This is urgent, this is chronic, this is congenital. In neonate or in pediatric, this is infection. Ask yourself, this is infection or this is congenital. Here in chest, there are four maximum, four pathology. Most of the pediatric chest are within them. Respiratory distress, meconium aspiration, CPAM, and the congenital diaphragmatic hernia. See here, if you told me, doctor, it looks like shifting of the mediastinum to the left, to the right, and so the pathology is here, despite this is positional, by the way, I will accept, but you should continue. Oh, doctor, I see here there are opacity. This is very acceptable. If you look here, my colleagues, there are multiple small cystic changes inside it. Then by CT, it becomes very clear, very clear. Opacity with cysts. First differential diagnosis is congenital adenomatoid malformation. Okay? Congenital adenomatoid malformation. Other differential diagnosis here may be also diaphragmatic hernia, but see, this is the diaphragm. This one, and this is stomach. This is the colon. Okay? So diaphragmatic hernia is not possible. Thank you, doctor, so much.
Thank you, sir.
Welcome. Next candidate, 5-year-old female patient, have a right-sided proptosis. Next candidate.
Assalamu alaikum.
Alaikum assalam. Request control. Go on.
Okay. I have been presented with brain CT scan, axial images for a pediatric age group patient with history of proptosis. I will scroll quickly through the image and then I will come back to my finding. I can see that there is proptosis seen involving the right side. I can see that there is exophthalmos that involving the right orbital. In my routine practice, I want to shift this image into the bone window
Why?
because
Why?
Because I suspected that there is difference between the sphenoid wing in the right side and the left side. I can see that there is thickening, thinning.
What is your finding? Tell me the finding.
Sphenoid wing hypoplasia, which is consistent with the
Hypoplasia.
neurofibromatosis.
See, hypoplasia or dysplasia?
Dysplasia, which is
Okay,
consistent with the neurofibromatosis
excellent.
type 1. So I want also to check if there is any nodules in the superficial skin.
Yes.
I cannot see any nodules, although in my routine practice, I want to shift or change the brightness of this image. And also, I cannot see any abnormal lesions within the rest of this study.
What is your next step?
My next step, I want to do full neural axis imaging involving the brain and the whole spine. I want to see
What type? What doctor? 1 second, 1 second. You didn't till now establish a definite diagnosis. So don't image the whole neural axis before you ask for a definite next examination or investigation for the brain. What is the next?
The next investigation will be a brain MRI.
Okay. This is the brain MRI.
Yes,
Go
I
on.
will scroll to see the. Okay, this is the bottom of the examination. So this is the axial images brain MRI flare sequence. I want to scroll until the last cut. Okay, I cannot see any signal abnormality within this.
Are you sure? Are you sure?
I saw this one.
Okay.
There is hyper intense lesion within this flare sequence seen in the area of the basal ganglia. I want to see the cerebellum.
And the other basal ganglia. What about it?
Yeah, I can see that there is similar but smaller lesion in the other basal ganglia.
Okay.
And also I can see that there is bilateral hyper intense signal which is noted in both cerebellar hemisphere. Also, I can see here in the midline there is rounded hyper intense lesion. I want to check them in the T2 sequence and also post contrast. In the post contrast images, yes, in this post contrast, this lesion didn't show avid enhancement.
What is the name of these lesions? The supratentorial lesions. What is the name? Give me a differential. Differential diagnosis for these lesions.
Because in the context of the neurofibromatosis type 1, this could be astrocytoma versus other lesions could be those of ependymoma.
No. What else? Do you hear about FASI?
Yes, I know the FASI.
Okay.
Which is focal.
Abnormal signal intensity. Focal
abnormal signal intensity. Yeah.
Okay. So give me a diagnosis. Conclude the
neurofibromatosis type 1.
Okay. And you will do the usual examination for the family, for the whole neural axis.
And genetic counseling.
Okay, thank you, doctor, so much.
Thank you.
See, the case start from here, my colleague. If we didn't pick up this one, I think in Viva, in real exam, the examiner will not give you a pon window. He will give you this one. If you pick up this dysplasia, okay, he will then give you the MRI and you will pass the case. But if you didn't pick up this one, you fail the case. Okay, my colleague. Thank you so much. Next candidate.
Standard Muslim in this interview.
Yes. Request control.
Sorry, sir, I'm not able to request control.
Okay,
Using from.
2-year-old male patient presented
Yes,
with
sir.
one second, presented with intellectual abnormality.
Okay, sir. Okay, sir. I'm provided with the weighted. So I think this is susceptibility images.
Look here
Image.
also. Look here.
Okay, sir. Okay, sir. Okay, sir. So in this images, this is a coronal image. I can appreciate that there are multiple. Okay, sir. Sir, there. Yes, axial images. Sir, I can appreciate that there are abnormal area of hyperintensity noted along the both paraventricular region with some dilated cystic spaces as well. This giving us some sort of triggeroid appearance, and
No.
these are
No
okay,
tigroid. Don't
not
confuse
triggeroid.
yourself. See? See?
Okay.
See,
Okay, sir.
this
Sir,
is
they
not the usual. Look here. What is this? What is this? What is this?
small cystic.
Okay.
Sir, these are perivascular cysts. Yes, yes.
Excellent.
Yes, sir. So, sir, these are predominantly bilateral, symmetrical, paraventricular, predominantly white matter involvement. With I also think they are up to sub U fiber also. They are also extending up to the
Yeah.
subcortical
Okay.
U fibers.
So what's
And
your
I also,
diagnosis?
sir, this is a dysmyelinating white matter disease. So I'm suspecting,
Again,
sir,
what is your
Kahneman,
diagnosis?
sir, white matter leukodystrophy.
Okay. Which type?
And sir, I think the calvarium is seen to be fine. There is no macrocephaly. I think it's not macrocephaly. If macrocephaly, then Kahneman is the most I think will be my
Okay,
first differential.
what else?
Sir, this second would be Alexander disease, but in Alexander, this is predominantly frontal involvement, but this is diffuse involvement, I can see.
This cystic changes or spaces
Yes,
is
sir.
very characteristic to one of them. Of
Sir,
this
measurable.
What?
Sir, measurable. One thing I did
No,
not
no, no.
remember.
No, 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 no.
Sir, then the third one be the metachromatic disease, but they have trigloid appearance basically.
This patient,
Yes, sir.
his lumbar spine show anterior peaking.
Okay. Holder syndrome.
So
Yes,
what
sir.
is the diagnosis?
Holder syndrome. Metachromatic encephalopathy, sir.
What else?
Yes.
This patient
Sir,
has hepatosplenomegaly.
Sir, the third one is X-linked leukodystrophy, but it usually involves posterior one. Is this a
This patient has many bone, restricted growth of the bone.
okay? Okay, sir. So
Myocopoli,
okay, sir. I think it may
mucopolysaccharide.
mucopolysaccharidosis.
Okay, why? Thank you. You mentioned most of the finding. What happened here?
Yes.
There are a white matter leukodystrophy. You can tell the examiner, see, for saving of time, doctor, there are bright periventricular white matter denoting leukodystrophy. Okay? Okay?
Yes,
associated with dilated prevascular vertebral space, prevascular spaces, and ventriculomegaly, and despairing. All of this, by the way, criteria of mucopolysaccharidosis, with sparing of the U fibers, sparing with the U fibers here. So my diagnosis would be a mucopolysaccharidosis, like this, but mucopolysaccharidosis is on top. Again, why?
Okay.
This is a leukodystrophy. Okay, so both the 5 most common, but how to characterize species in mucopolysaccharidosis, this Virchow open species, which is dilated. I will tell you something non-scientific. What happened here? The polysaccharidosis come and occupy all these spaces, like ice cream spaces. You will never forget it. This is polysaccharidosis means sugar. Okay, so this is ice cream spaces. Virchow open spaces filled with sugar, filled with mucopolysaccharidosis. You will never forget it. Okay, my colleague. And then you will see this ventriculomegaly and the other side, mucopolysaccharidosis. This is a leukodystrophy. Doctor, what is the difference between demyelination and demyelination?
Sir, in demyelination, there's the inflammation. Demyelination is abnormal white matter. There's like abnormal growth. And
No, both of them are inflammation. See, 1 second. Both of them can be inflammation. But
sir, demyelination are usually congenital. I read that they are like abnormal white matter in the growth.
Yes, this is the decimal. And what about the demyelination?
Demyelinated occurs later on the stages of the life with the inflammation of the white matter.
Acquire.
Acquired.
See, acquire. Demyelination acquired. Demyelination is congenital. Thank you, doctor, so much. Next candidate. Request control, please.
Okay, hi, doctor. I requested.
Two-year-old female patient presented with gait abnormality.
Okay, this is an MRI, axial MRI T1 for a patient presented with gait abnormality. Let me check the whole sequences.
Look here, please. 1 second. Look here. This is T2.
Okay, this is a T2.
1 second. Okay, yeah, go on.
T2 axial cuts. I can see that there is periventricular and deep white matter high signal.
Sorry. Oh. Okay.
In T2. Bilateral periventricular, deep periventricular and deep white matter high signal in T2 with tigroid appearance.
Okay, what's your diagnosis?
This is a leukodystrophy.
Okay, which type?
Metachromatic leukodystrophy.
Okay, what is the underlying cause of metachromatic leukodystrophy?
Mitochondria. This is one of the mitochondrial diseases.
Excellent.
I'm not sure.
No, see. Like every day, the first, what is in your mind is the correct, really,
okay.
Is the correct answer.
Okay.
Okay, what else? Give me from this examination another criteria of the metachromatic. What happened here?
It's involving the U fibers.
Excellent. So the metachromatic is tigroid, U fibers, and what else? It gives a characteristic shape.
The tigroid appearance.
And
Mm.
Is this
But that's
butterfly? Is this butterfly or not?
yes, yeah,
Okay, so this is a metachromatic loco.
dystrophy.
Okay, what is your treatment?
Treatment?
Yeah, what do you think about the treatment? You have any
Maybe
clue? You told
physiotherapy.
me yes.
Med-
Hello?
yeah, I'm thinking doctor, but it's a mitochondrial disease, so I'm not sure what they are giving for mitochondrial disease actually.
Okay, no problem. But do you know why the metachromatic leukodystrophy giving the tigeroid appearance?
Yeah,
Yani, like here, see?
I know, but it's not in my mind now.
Okay, see, the
Some because
tigeroid bright, alternative bright, and
mm,
low signal.
those
What is
signals.
this low signal? What is the name of this structure?
Um,
Venule.
someone.
Venule,
Mm,
because the demyelination is pre-venule here. Okay? See, all
okay.
this question is not expected in the exam, by the way, but I just activate our knowledge, all of
Mm,
us. Okay? Thank you, doctor,
yes.
so much.
Okay,
It
thank you.
was another leukodystrophy, uh, demyelinating disease of the brain. This is a mitochondrial related abnormality. At least we will transfer to the pediatric neurology for further management. Now the gene therapy has a great progress. One of my professor last week told me they have a new era in USA um, about the gene related or DNA related radiology. I don't know why. I don't know what this new science. But he told me there are a very new era will change the radiology completely. From the radiological examination, they can tell in USA many good information about يعني the gene types of the disease, many details. I don't know this new era, but very great news. Thank you, doctor, so much. Next candidate.
Yes, Doctor. Assalamu alaikum.
Wassalam. This patient, female, 0 day, presented with shortness of breath.
Okay, so I'm presented with the frontal chest X-ray of a neonate. Here I can see that the endotrache. First, I would like to comment on the lungs and tubes. I can see the endotracheal tube in situ at the level of clavicles. A tube is seen, which could be a likely NG tube, which is in the thoracic on the thoracic vertebra and is not reaching and in the stomach. And this catheter is likely an arterial catheter in aorta at the level of T6 and T9. The bilateral lung fields are hyperinflated, and I can see that there are multiple coarse granular opacities seen in the bilateral lung fields, more marked in the mid and lower lung zones. And I would like to know the history of the patient, if the patient is a preterm, term, or post-term patient.
Both term. He is both term.
Post-term. Yes, then my top differential would be of meconium aspiration syndrome, as the
Excellent.
coarse granular opacities with hyperinflated lung fields are more suggestive of this. I will immediately convey the findings to the referring clinician. This
What
patient
is the
needs.
underlying pathology of this granular opacity?
These are due to the subsegmental atelectasis with areas of air trapping
And what else?
and meconium, which are giving these dense opacities.
Okay. What else also? meconium cause something to the lung parenchyma itself?
Yes, it causes chemical pneumonitis.
Excellent. Excellent. What is the most common association of the meconium aspiration?
The most common association of meconium aspiration um,
In the lung.
sorry, in the lung.
Yes, yes, sure, in the lung.
Yeah,
What will happen?
sorry.
What, what finding almost you should find in the X-ray, chest X-ray?
Findings of there are they can be pleural effusions as well,
What
and
else? What else? Okay, what else? This meconium obstruct the bronchi, so subsequently it may complicate by something.
atelectasis.
What else?
And
Pneumo, pneumo,
pneumomediastinum,
and or pneumothorax.
pneumothorax.
This is very characteristic. يعني
Okay.
see, if you want to be 100% sure this is a new meconium aspiration, number one, ask about the history. You are correct. Number two, either signs of hyperinflation or signs of pneumothorax, pneumomediastinum. Very characteristic, okay? Because
Okay.
why? If any candidate said, okay, this is granular and they both respiratory distress as a differential, is accepted, okay? Except why? Because this is X-ray is not contain all the criteria of meconium aspiration. However, after I telling you this is obstructive labor, so meconium aspiration should be on top of your differential diagnosis list. Thank you, doctor, so much. Next candidate.
Thank you, doctor.
Assalamualaikum, sir.
Request control, please.
Sir, I requested.
Okay. 11-year-old patient has fever and vomiting and neurological manifestation. Go on.
Okay, sir. So I'm scrolling from bottom to top. First, I will review all the findings and then I will comment. I'm provided with the CT plain images of a pediatric age group patient in which I can appreciate some mouse is working a bit slow. I can appreciate normal cerebral parenchyma, but there is bit enlargement of bilateral gyri, and there is effacement of sulci in the supratentorial region, and I can
Look here.
appreciate in the
Look here.
extra
Look here. What happened?
in infratentorial right cerebellar hemisphere, I can appreciate a hypodense lesion with in the posterior and lateral aspect, and there is hyperdensity of the right transverse right sigmoid sinus as well. Fourth
No,
ventricle
this
is
is not.
slightly
This is normal. What happened
okay.
here?
Sir, there is diffuse hypodensity of the right cerebellar hemisphere as well as bilateral cerebral peduncles, and midline vermis and left cerebellar hemisphere appear normal.
Yes.
And I would like to see this on post-contrast images to look for any enhancement.
What's your concern first before asking for anything? Tell me your concern. Patient has fever.
Sir, I am thinking in the line of infection that the patient is likely having cerebritis or
Okay.
focal basilar meningitis, which is involving the brain parenchyma.
Okay.
So,
See, this is MRI. Go on.
okay, sir.
Roll, doctor.
So, not working. Mouse is not working. I have again requested control. Sir, there is I'm provided with the FAT-SAT T1 weighted images of the brain of the same patient in which there is diffuse signal abnormality involving the right cerebellar hemisphere and there is
Is
complete
this T1,
defacement of
doctor?
the
Doctor, this T1.
uh,
Look here.
sir,
Which
this is FLAIR.
sequence?
This is
Okay.
T1 FLAIR images are provided and there is diffuse high signal abnormality in the right cerebellar hemisphere and
Okay.
midline vermis and left side are normal. So I'm the diffuse abnormality is on post contrast sequence. I cannot appreciate any significant enhancement.
What's your
There
diagnosis?
is, sir, without significant enhancement and involvement of whole of the lobe, I am.
Remember the history, please.
Sir, the history is concerning for some underlying infection, like patient is
Okay.
having fever. So,
Okay. What
without
is the
any
name of
enhancement,
what is the name of the pathology here? Infection or inflammation of the cerebellum?
sir,
Cerebellitis.
cereballitis or
Oh,
cerebritis.
okay.
Okay.
Cerebellitis. Okay. Thank you,
Okay, sir.
doctor, so much. This is a child and they have a cerebellitis. Okay. Thank you, doctor,
Sir, I
so
have
much.
one question.
Yes, sure.
Sir, I have one question. Sir,
Yes.
why the cerebellum is not enhancing on post-contrast images?
See here. Why? You should tell me why. For example, in herpes simplex, could you detect any restricted diffusion or enhancement?
Sir, there is mild enhancement in subpattern with hemorrhagic convergence usually, and there is
Yes,
mild diffusion restriction as well.
yes, but almost it can be presented with no contrast enhancement. Okay.
Okay, sir. So this is herpes simplex infection.
See. In my experience, according to the infection especially, overall, it didn't take a good degree of enhancement. It may take patchy, mild, no enhancement like this. Okay?
Okay, sir. Okay, sir.
Okay, this is my experience. However,
Okay, sir.
if you detect enhancement here, it will confuse you so much. Why?
Okay.
The same appearance of this one may confuse you with Lahermit-Douglas syndrome. But the folia is more prominent, I know, but
Yes.
I'm generally
Yes. Yes.
speaking. I'm generally speaking.
Okay.
Thankfully, it show no uptake here. So it
Mm-hmm.
is a good sign for us, a good differential sign for us between cerebellitis and the Lahermit-Douglas syndrome, that there are no obvious enhancements. Otherwise, we will be
Yes.
confused in between both of them. Okay?
Oh, okay. Thank
Oh,
you, sir.
welcome. Next candidate.
जी सर अस्सलाम वालेकुम
Salam. Request control, please.
Yes, sir. I have requested. So I'm provided with the X-ray abdomen.
2-year-old male patient. I think Okay, he has consider abdominal pain. Okay, he has abdominal pain. Tell me.
Okay, 2-year-old male patient with history of abdominal pain. Okay, so this is X-ray abdomen.
Yes.
He is in the upper abdomen as well as on the right side, and the bowel loops are displaced towards the left side.
Okay.
So I cannot see any free air under the diaphragm, or I cannot see any free air.
Okay. What is
So,
your
sir,
concern?
this could be due to any mass lesion. So I would recommend ultrasound of this patient, and will inform my finding to the concerning physician. I will. Okay, so these are ultrasound images of the same patient. So I can see. So this is a bowel loop with the thickening of the bowel wall.
Okay. What is the name of this sign?
Not sign appearance.
What?
So giving a donut sign appearance or
Okay.
pseudo
So
kidney sign.
what's your diagnosis?
So this could be due to intussusception.
Excellent. What's your management?
Sir, in children, mostly it is due to lymphoid hyperplasia, or most of the cases are idiopathic. So I will inform my finding to the referring physician and would refer the patient for sir. Sorry, I forget the name of the procedure, sir. Like it's a radiological procedure in which we reduce this intussusception.
Yes, excellent. Reduction. What is the type of reduction?
Yes.
How many types do you have?
So we can do with air or
pneumatic reduction or
yes. So with the
with the
contrast
water or
yes.
hydrostatic reduction. Okay. How many attempts are allowed for pneumatic reduction? How many attempts?
So three times,
Okay.
sir.
For how many minutes each attempt?
So the rule of 3 minutes.
Okay. The maximum pressure of air. What is the maximum pressure of air?
80 to 120. I think.
Excellent. More than excellent, doctor. But this patient is, can we do this reduction for this patient? Yes or no?
Sir, I really don't know.
Yes or no? This patient is fit to do this reduction or not?
Yes, it's very difficult in fatty and obese patients to do pneumatic reduction.
No. From X-ray, do you find here pneumothorax and pneumoperitoneum?
No, sir.
So this patient is fit for reduction. The only contraindication is perforation. Okay. Thank you, doctor, so much. The scanty of gases here is the key. Okay. The scanty of gases here due to intussusception, then the doctor requests ultrasound and the usual intussusception. Thank you, doctor, so much. Next candidate. Hello. Next candidate. Dr. Nagam, who is the next candidate?
Yes, sir. I think all of them are available.
Again, anyone available?
Candidate 12 is around, yes. I just saw him.
I'm candidate 16.
There is candidate 12. Please join. Okay, we can take 13.
Okay.
We can take 13.
39, 13, sir.
Okay. Thank you, Dr. Nagam. Thank you. This is 16-year-old female patient with a history of acute abdominal pain and fever and urinary tract infection. Okay?
Okay, sir. Sir, I'm requesting control.
Okay.
These are, so just give me up the second, please. These are CT brain images, non-contrast enhanced in a 16 years old female,
Yes.
in which I can appreciate. I will take a moment to go through entire stack. It has finished. The patient presented with fever, and I can appreciate that I cannot appreciate any significant pathology on this particular image. There's some wavy convolutory margins around the ventricle, along the ventricular margin, and there are some faint hyperdensities are seen in the subcortical region. I would like to change the window of the study to characterize further the ventricular system. Yes, I think there are some wavy margins, and I would also like to know the history, if the patient has any history of mental retardation.
No mental retardation. And all the signs that you mentioned, don't worry about it.
Okay.
See, look at this examination. Tell me what happened.
Okay. In this MRI brain T2 axial sections, I'm trying to look for, there is no significant abnormality. Some hyperintensity is seen within the midbrain. It is central, and there is pairing of what else? There is diffuse hyperintensity seen in bilateral parietotemporal lobes.
Okay.
I would like to see it on any other sequence as well.
Which sequence do you want? Look here.
Sir, I would like to see diffusion. This is FLAIR imaging. This is FLAIR. FLAIR shows some hyperintensity. There is, sir, it is in bilateral basal ganglia and both posterior parietal cortices, parieto-occipital cortices. And yes, the white matter is also showing some hyperintense changes. I would like to see the same findings on DWI and ADC mapping to see that whether they are due to some hypoxia. I'm thinking in line of hypoxia. This is showing hyperintensity. There is bright signals. I would like to correlate it on ADC mapping to see that whether these basal ganglia and these cortices become low on ADC. There is diffusion. Yes, there is positive diffusion restriction in bilateral white matters and corpus callosum.
What's your concern? Bilateral, symmetrical?
So my concern is that it could be hypoxia. It could be due to
what else?
Any drug reaction.
Okay. So you are thinking about something systemic.
Something systemic, yes, that has affected it.
So my colleagues always tell the examiner what is in your mind. This is very important buzzword. Really, when you told the examiner you are thinking about a systemic disease, so the patient will transfer to the internal medicine or to the pediatric. Big difference. When you are thinking about a localized disease here, we will send the patient to a neurology. A big difference. Very big difference. Okay? So this is systemic. You told me hypoxia. What else? See, bilateral symmetrical basal ganglia, and the corona radiata, and the central semisphere, and the cortex. What else?
Cortices.
Yes, besides the
Sir,
hypoxia.
it can be encephalitis or post-shock.
No. The encephalitis will not symmetrical like this. Which metabolic disease can cause the same picture?
Sir, diabetic ketoacidosis, diabetic
Excellent.
coma.
Excellent. Then this patient, after follow-up, see what happened. By the way, my colleague, this case may be a long case, long reporting. Okay, but he will not bring all this sequence. He will bring 1 or 2 sequence in from each stage of this one. Okay, like this. What happened here, my doctor?
Sir, in this image, this is FLAIR sequence, and I can appreciate that the bilateral posterior occipital region and some foci in the cortical and subcortical regions are showing hyperintensity. And this is the posterior hyperintense foci. I will try to look at whether they are reaching till the periphery of the brain or to rule out any. I'm thinking in lines of they can be infarction or it can be press.
Yes. I
Press
wanted
is,
to ask you, but answer me honestly. What is in your mind first? Infarction or press?
Sir, it looks like asymmetrical bilateral posterior lobe reaching till the periphery.
Okay.
I am, sir, as patient is young and there is a history of admissions and there are hyperintense foci in bilateral parietal regions as well. I want to keep the infarction as the first differential.
No.
It can be press.
How could an infarction be bilateral like this? Anyway, they did MRV. Only I think it is MRV, and it was normal. Okay, no problem. You are correct also. See, it is normal. Okay, so what is your final diagnosis?
Sir, my final diagnosis is that patient has a recent history of diabetic ketoacidosis resulting in brain involvement, which has resulted in posterior reversible encephalopathy.
Excellent. Exactly. It was the answer. It was a case of diabetic ketoacidosis, like as we seen in the previous MRI, and after few days it complicated by breast due to what is the underlying pathology of breast, doctor? Could you tell me?
The underlying pathology is, sir, I don't remember. It is related to ischemia.
No. It's related to disruption of the autoregulation of the brain. Okay. Disruption of the autoregulation of the brain circulation. Okay. Thank you, doctor, so much.
Sir, just one question.
Yes.
One quick question. Sir, if the examiner brings CT like you did and I wasn't able to get anything out of it, what will be our first step?
Either ask for history or ask for MRI. Okay. But here there are some few things here. Here, I think the CT was not conclusive at all. So ask for MRI. Sometimes they want to assess what is your next step. He bring you a patient with a very significant complaint. Okay, and you are not sure there are this CT about this CT. Okay, you can't detect anything, so ask for MRI. Okay.
Okay, sir. Okay, thank you so much.
Thank you so much. Despite there are, you can consider that there are some edema, but really very subtle signs here, very subtle. Okay, I'm trying to see something here. Very subtle. Ask for MRI. Thank you, doctor, so much. Next candidate.
Hello, sir. I'm candidate 14.
14, okay. This patient, a preterm neonate.
Okay.
Go on.
I'm presented with axial non-contrast CT scans of preterm neonate.
Yes.
I can appreciate that there is gross supratentorial and infratentorial ventriculomegaly.
Yes.
There are areas, hypodense areas noted in periventricular areas, which are suggestive of leukomalacic changes,
Okay.
leukomalacia and
Okay.
encephalomalacia, sorry. And
Okay.
there is cortical thinning, and I can see that the bilateral thalami are separated, and
What about
there is
this,
also
doctor?
presence of
Doctor, what about
septum.
this one?
Okay.
What about this?
So can you please scroll? Okay. There is an ill-defined soft tissue lesion in intraventricular septum attached with the intraventricular septum.
Yes.
Sir, can I see other sequences and other
This is
images
ST.
post contrast?
No
Yeah,
post
sorry.
contrast. What is your
MRI.
next
Yeah,
step?
yeah.
MRI.
I
Okay.
would want to see post contrast CT images or MRI images.
This is
Yes.
MRI.
Yes, I can appreciate that there is this is MRI flare sequence or
This is T1. T1.
T1 contrast.
No, not contrast. T1.
T1. I can see a bright lobulated, bright hyperintense lesion which is attached with the interventricular septum. So my
Yes.
diagnosis would be, I would want to see the post-contrast images to see whether it is enhancing or not. My
No post
diagnosis would
contrast.
be
See,
for
this is T2 only. T2, no post contrast.
okay, it is hypointense in T2.
So, what does it mean?
It means it may be blood.
Excellent.
Blood.
Intraventricular
So
blood with marked ventriculomegaly. What is your diagnosis?
yes, so this is intraventricular hemorrhage causing
Yes.
obstructive hydrocephalus.
Yes. So, what's your diagnosis? See, after follow-up,
It is
the blood decrease in size.
yes.
What is
So this
the
is
name of your
this is a
diagnosis?
preterm neonate. Preterm neonate. So
Yes,
this is
yes.
type 4 germinal matrix hemorrhage.
Excellent. Thank you, doctor, so much. This is
Thank you,
a
sir.
type 4 germinal matrix hemorrhage. Okay. Type
Yes.
1 in the caudo-thalamic groove. Okay.
Yes.
Here
Type
the anatomy is completely disturbed, completely destroyed anatomy. Type 2, type 4 is the interventricular and plus hydrocephalus. Between of them, there are type 2 and type 3. Okay. Type
yes.
Type 2 is a paraventricular. Type 3 interventricular without hydrocephalus.
Yes.
Okay.
And type 4 is
Type
with
3.
hydrocephalus.
Yes.
Type 4. Type 4 is with hydrocephalus. Intraventricular hemorrhage with hydrocephalus.
Yes. Let's revise them again type by type because this is very important. Very important. The germinal matrix, by the way, at the caudo-thalamic groove between caudate and thalamus. Very important. Very important here, my colleague. Type 1 is restricted to a subependymal region in the caudo-thalamic groove. Type 2, extension into normal size ventricle. Okay. Type 3 Type 3, okay. Type 3 extension of the hemorrhage into the ventricle, and the ventricle is dilated. Type 4, there are parenchymal involvement. Okay, my colleague? Anyway,
Okay, sir. So this is type 3. Sir, this is type 3.
No. What? See, 1 second. We have a parenchymal involvement, doctor. In our case, see in our case. What happened here? What happened for this parenchyma, doctor? The parenchyma, you talk about the leukomalacia. See? What is the underlying pathology of this leukomalacia? Almost this hemorrhage. Correct? Correct or not?
Okay, sir. Yes.
And we don't know what happened here. Almost this hemorrhage may be we're here. I think this is very late stage. Yani I think what happened first, the bleeding start normally at the caudo-thalamic groove and then extend here, and then this is dilated and then extend here. Okay. So there are parenchymal involvement type 4. See, doctor, to be sure also. What is germinal, grade 4 germinal matrix hemorrhage with intraventricular extension and hydrocephalic changes. Thank you, doctor, so much.
Thank you.
Last candidate.
Yes, sir. Assalamualaikum.
Alaikum salam.
Sir, I've requested control.
Yes, this is a child have headache.
Child and headache. So these are MRI T2.
Static, I think.
Sir, I'm scrolling.
Static.
Okay, it's a static image. It's MRI T2 weighted image, axial, corneal, sagittal, and it is showing dilatation of the lateral and third ventricles. Fourth ventricle appears normal. So this is a case of obstructive hydrocephalus, likely due to aqueductal stenosis. I don't see any tonsillar herniation. This is an emergency. So I would urgently refer to the pediatric neurology for urgent decompression.
Excellent. What is the most common cause of obstruction here? Give me
Sir,
one or two causes.
stenosis.
What?
Stenosis. Sir, stenosis.
Okay, what else?
Sir, it could be because of a mass lesion.
Web. Not mass.
Sorry?
Okay, mass. From where the mass originate?
Sir, mass would originate from the stectal plate.
Excellent. Or the pineal?
Or yes, the pineal gland as well.
Or there are a web here. So either a pure stenosis or a web or a mass from a tectal plate or pineal. Thank you, doctor, so much.
Thank you, sir.
I think, Dr. Nagam, we finished today our list, okay?
Yes, sir. Thank you so much.
Okay. See, my colleagues,